Good afternoon. My name is Diane, and I will be your conference operator today. At this time, I would like to welcome everyone to the Creating an Effective Peer Model conference call. All lines have been placed on mute to prevent any background noise. Questions will be taken over the WebEx throughout the call, which can be seen in the lower right-hand corner. Questions may be asked through the chat at any point throughout the call. Additionally, after the speaker's remarks, there will be an audio question and answer session. If you would like to ask a question during this time, simply press star 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Amanda Hopping-Wynn, you may begin your conference.
Thank you. Good morning and good afternoon to some of you. I'm Amanda Hopping-Wynn, Project Analyst here at the National Abandoned Infants Assistance Resource Center located at the University of California at Berkeley. I'd like to welcome you to the final webinar in our 2012 series. We're joined today by Dr. Paul Colson and Tina Rodriguez, who will present Creating an Effective Peer Model. Dr. Colson holds master's and doctoral degrees in social work from the University of Chicago. He serves as project director for the Peer Advanced Competency Training Project and program director of the Charles P. Felton National Tuberculosis Center at Columbia University. Dr. Colson is experienced in designing and conducting interventions using peer educators. Additionally, he has extensive experience in designing and delivering peer educator trainings. His first experience with peer educators was a violence reduction project with Chicago street gangs. More recently, at Harlem Hospital, Dr. Colson has served as a co-investigator in several randomized clinical trials of peer interventions, including the Pathways to Completion study, the Harlem Adherence to Treatment study, and the Tuberculosis Adherence Partnership Alliance study. In these projects, he took primary responsibility for the design of the peer intervention and for conducting training and supervision of the peer educators. Tina Rodriguez is a family support specialist with Fresh Start, working with pregnant women and new parents who are affected by substance use disorders and their children in Massachusetts. Mrs. Rodriguez uses her lived experience as a mother in recovery from addiction to inspire and connect with clients and providers, and to show them that anything is possible. Her work is a chance for her to give back. Every day that she goes to work, she is helping others to get one day closer to what she has: happiness, recovery, security, self-confidence, and stability. She also enjoys her work as a puppeteer, addressing issues such as bullying prevention and parenting skills. She and her husband have come into recovery within their relationship, and they have a 9-year-old son. Mrs. Rodriguez is currently enrolled in the Human Services Associate's Degree Program at Holyoke Community College. Thank you both for being here with us today, and at this point, I'd like to turn the call over to Dr. Colson.
Okay, thanks very much, Amanda. Good morning, good afternoon to everyone. I'd like just to briefly talk about the objectives for my portion of this webinar. By the end of the webinar, participants will be able to describe steps for creating an effective peer model, including identifying ways to structure a peer program within your organization, describing roles and responsibilities for peers, describing training and supervision for peers, and describing the value that peers bring to HIV care systems. This slide is a quote from Rebecca Dennison, who founded an organization called World, and I'll tell you a little bit more about that organization in a minute. They're located in Oakland, California, and the name stands for Women Organized to Respond to Life-Threatening Diseases. She said, "When I was diagnosed, I felt like nobody could possibly understand what I was going through. I would have given anything to have another HIV-positive woman to talk to right away. When I finally did meet another HIV-positive woman, she gave me hope. She had information. She gave me courage. Now we can give other women what we only dreamed of before." So I just wanted to give you a little bit of background. Amanda did mention some of the programs I've been involved with, and she did mention that my first experience with peer workers was a violence reduction program with gangs in the early 80s. We hired former gang members and teamed them up with social work students to do street mediation. Now, some of you might be saying, what does this have to do with HIV peers? The commonality is that members of a target community are working with credentialed workers to achieve common public health goals. Peer workers often go by other names: community health workers, lay health advisors, promotores, but essentially I believe there's a commonality in these different programs. Someone who's from the community, who has had a certain experience, is working with professionals. I've also worked with programs in which the peers have psychiatric histories. That is, they've often been hospitalized against their will or medicated against their will, and have, following hospitalizations and through a recovery process, are now able to work with other psychiatric patients in the community. This slide, again, shows some of the programs I've been involved in, not the first one, which was started by my boss, Wafa El-Sadr. That was before I was at Harlem. But the peer adherence programs, beginning in 1996, I was involved in. And through the 2000s, peers have become integrated in a number of programs of the Infectious Diseases Department. Now, following these programs at Harlem Hospital, we are funded by HRSA as part of their peer education initiative. And this initiative funded 4 sites that you see on this map. There's a resource and evaluation center called the Peer Center at Boston University in the upper right, and then 3 peer education training sites. Each of those 3 sites had a peer program serving its community, which offered training and technical assistance to organizations who wanted to develop new programs or strengthen their existing program. And these 3 sites were PACT, the project that I ran in Harlem, based at Harlem Hospital in New York, the People to People project in Missouri, which was a partnership between 3 organizations, the Kansas City Free Health Clinic, the St. Louis chapter of the American Red Cross, and the Missouri AIDS Education Training Project. And finally, there was the Lotus Project in Oakland, which was a partnership between World, the organization I told you about before, and the Center for Health Training. So a lot of what I'm going to be talking about today comes from the collective wisdom of all of the people involved in these projects. First, I think it's important to talk about what a peer is. A peer is a person who's not working as a licensed clinical professional. Now, it could be, of course, that you have a social worker or a physician who is HIV positive themselves. But I would suggest that's not a peer worker, because they were not hired for the reason that they are HIV positive, and their job is not to share their experiences necessarily, but instead to be a social worker or a physician. A peer is a person who shares key characteristics with the target population, such as membership in a certain community, gender, race or ethnicity, disease status or risk factors, or salient experiences, such as former drug use, sex work, incarceration. And then the peer uses those shared experiences or characteristics to act effectively as an educator, a mentor for adopting health behavior, a role model, and an empathic source of social and emotional support. Here is our criteria for peer work in our adherence programs at Harlem Hospital. Some programs use peers who are HIV affected but not infected, particularly for prevention work in HIV. But if you're using peers to support antiretroviral therapy, they should, again, serve as role models. Oh, I'm sorry, I didn't change the slide there. Sorry. They should serve as role models and thus be adherent themselves. That's the first bullet you see on the slide, being adherent. Now, the next bullet has to do with being a Harlem resident. Obviously, that's our criteria, and your location, you would define what you need from the peer in terms of their familiarity with a certain context. We've never had a problem finding peers who are committed to ending HIV/AIDS, who are willing to give of their time and experience. Fourth bullet, good communication skills, that's a must. Peers can be trained on how to start a conversation with a client, how to establish rapport, but a very shy person probably would not be an effective peer. And not currently abusing drugs. And that's an issue I think we should take a minute to talk about. The substance abuse issue is a tricky one. It is normal in regular human resources hiring processes to confirm that an applicant is not currently using drugs. In some systems, employees may not be retested or retested only rarely. Now, if you are hiring peers with a substance abuse background, you may be tempted to test them more often than other employees. And I would just caution you that when you treat them differently than other employees, you may open yourself up for complaints or even lawsuits. Often with peer programs, we do hire peers who have a personal background in substance abuse, because we think they can better reach and serve people who are currently abusing drugs or substances. We have to realize the extreme risk that we're placing the peer. And this is what I mean by putting your head in the lion's mouth. We're asking them to relate to the very same people they used to do drugs with or go to the same places. This can be very dangerous. At Harlem, drug testing was only performed at hire and then on an annual basis thereafter. So this really puts an emphasis on the supervisor, the peer supervisor, to be aware of the pressures the peer is under and to recognize signs of stress and possible relapse, and to work proactively to prevent relapse. And sometimes people have a lot of questions about the substance abuse issue. I'd like to open up the lines in just a minute, but first I'd just like to read this quote from one of our peers, which sort of sums up the things that peers do. I like seeing the clients come in and reach a different level when they leave. The clients looked at the peers and saw how they lived, that they stopped using drugs, they were working, they were taking their medication. They saw how much better the peers were getting, and they would say, I want to be like that. So again, I think this might be a good time. If people have questions about anything I've said up to this point about what a peer is, or want to talk particularly about substance abuse, the slides coming up are more about program design and less about peer characteristics.
So Diane, could you open the line for questions or cue the questions from our participants?
At this time, I would like to remind everyone, in order to ask a question, press star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile a Q&A roster.
And Paul, I wanted to note that many of our participants are working with peers who are not affected by HIV, as their programs work mainly with mothers affected by substance abuse. So I wanted to reassure everybody on the call as well that while Paul's direct experiences with HIV-positive peers, that the program design slides can be transferred to any peer program.
Your first question comes from the line of Susan DeFilippo. Your line is open.
Yes, hi. This is Kathy Crowley. I'm sitting with Susan. I had a question about the training and or supervision of the peers that you utilized in your program. What type of training they go through? Do they get training on ethical boundaries?
Certainly the quick answer is yes. I'd like to defer providing more detail at this time, though, because that is something I'll get into a little later, and I have a number of slides both about training and supervision.
Great. Thank you.
Mm-hmm.
There are no further questions at this time. I turn the call back over to the presenters.
Thank you.
Okay. Thank you for your reminder, Amanda, about the participants on the call and the nature of the work they're doing. Amanda had asked me in advance about whether I could address substance abuse among the peers, and I said, well, as a matter of fact, all of our peers that I worked with had a substance abuse history. Even people who identified more as having gotten HIV because they were a gay man also had a substance abuse history. As I thought about that, wasn't quite true. We had 2 peers who are Africans, because there's a sizable African population in Harlem, and they didn't have that background. And often that's what you find in terms of Africans in the United States who have HIV, is it's different modes of transmission, particularly heterosexual. So we'll move ahead here. What you see on the screen here is the cover and table of contents to an online toolkit. The 4 organizations that I mentioned earlier collaborated to create this online toolkit to summarize not only our experience, or even less our experience, but more to provide resources and ideas on peer programs. And the organization you see there, the table of contents, I think is a logical order, and it pretty much mirrors what I'm going to do today. I'm going to try to hit all these points: organizational readiness, program design, roles and responsibilities, recruiting, hiring and orienting, supervising, evaluating, and funding sources. This is one of 2 online toolkits. We never produced a printed version because it would just be too large. It would be hundreds of pages. Because with each chapter, there are attached appendices that give you, say, sample job descriptions, tips for supervision, a whole variety of things. So it would just be unwieldy to actually print the thing out. But you can access this at the address that's at the bottom of the table of contents there. So the first step in thinking about a peer program is to assess organizational readiness. Many peer programs have begun with the enthusiasm of a single individual, only to see things fall apart once other people in the organization learn about the program and start to question it. So the first thing you should ask yourself is, what do you hope to accomplish with a peer program? What are your organization goals, either in enhancing or beginning a peer program? Why are these goals important? Where do you need to get buy-in to support this effort? I would suggest that you try to verbalize your vision of what the peer program would do using these sort of questions. How does your organization view peers? What roles and responsibilities would they have? In what ways do peers interface with other members of the organization? And here's some of the examples we've collected when we've given technical assistance to organizations. The first one, our peers are integrated into our team as full members by exchanging relevant information about clients regarding adherence to medication and healthcare appointment struggles. Our peers meet clients one-on-one and in small support groups. Another program said, our peers work with our case managers and healthcare providers to follow up with patients who have missed appointments in order to re-engage them into care. Another one, our peers work to reach clients in the community to provide education and promote self-advocacy in managing their HIV healthcare. So here's 3 different visions. I would say the first one mostly reflects adherence support, where the peers would probably be located in a clinic working with doctors, nurses, etc. The second one refers more to peers being used for retention or return to care, to find patients who are not coming in regularly and try to get them back into care. The third one is more of a prevention or education type model. So you'd use this vision to start to think about program design. Organizational buy-in is essential. The peer program must work to achieve agency goals. Now, a lot of times people say to me, I don't have the funds to pay peers. Does that mean I can't have a peer program? Our programs at Harlem Hospital developed out of volunteer programs. And for people who are on benefits because of their HIV disease, paying them a livable wage may not be necessary or even may jeopardize the benefits they're getting. So it may be possible to, quote-unquote, pay peers with stipends or in-kind goods or other forms of compensation. It's vital that you're clear about roles and responsibilities. There's a 4th bullet here, including job descriptions. And you need to establish clear training and supervision systems. And the final point, you need to inform people, including the clients and other providers on the care team, about the peer program. We've seen the unfortunate situation where a client may be talking with his or her doctor, and the peer is standing by, and the doctor saying, "Who's this? Why is this person in the conversation?" If the doctor's not aware that it's a peer program, they certainly won't appreciate it, and it could lead to embarrassing situations like that. Now, the vision statements, again, told you about some of the roles that peers could play. This is a slightly longer list, and this is how we use peers at Harlem Hospital for pre- and post-test counseling, for patient navigation and retention in care, facilitating support groups, providing referrals for in-house services and community resources, and for supporting antiretroviral therapy adherence. Those are the programs I'm most familiar with. The peers provided social support and promoted adherence in their weekly contacts with each client. They helped the clients adapt the regimen to their lifestyle. They facilitated communication with providers, sometimes just helping a client prepare for an examination with a doctor, or other times even being in the room. And they served as a role model. Now, this slide suggests some things that peer support isn't. It shows things that sometimes peers think they can do, but generally shouldn't. Peers should offer their own experience, but remain cautious about forcing certain choices on their clients. Something we always have to remind the peers is if they have a certain regimen that's worked for them, doesn't mean it's going to work for everyone, and they shouldn't be pushing their clients to go on the same regimen they're on. And that can be interpreted more broadly, too. The things that one does to adapt to the disease and even like recover from substance abuse vary across individuals, and there's no one way to do anything. Peers should be able to provide health information to clients, but should also be aware of the limits of their knowledge. Sometimes when a client has detailed questions, it's better that either a health educator or a physician address those, and it's better that the peer says, you know, I'm not quite sure I can answer your question. Let's go talk to the health educator. Now, thinking about how healthcare professionals view peers, I would say they generally make the opposite mistake. They undervalue the contributions that peers can make. And as a result, sometimes peers are used for menial tasks, such as filing or greeting people as they come into the clinic. This comes from not understanding and appreciating what the peer offers. Their understanding of what clients are going through, the fact that they have time to sit and talk with their clients, and a commitment to do what they can to fight the scourge of HIV/AIDS. I know this slide looks a little busy. This came from, our collective experience across these several organizations, realizing that there's two fundamental ways that peer programs are structured, and what we called an internal or an external model. And as you look at this, I'll just sort of talk through some examples. In our peer programs at Harlem Hospital, we were using the internal model. The peers were hired by the hospital, they received a stipend, they received specific training in their job duties, and they're introduced to other staff, physicians, nurses, health educators, case managers, social workers, as part of the team. And they would meet with these other professionals in multidisciplinary case conferences. The World program that I referred to at the beginning is an example of the external model. Peers working for World were hired and supervised by World. The HIV-positive women in need were referred to World for their services, and they were assigned a World peer who assisted them at whatever clinic or hospital where they're currently getting care. So thus, in that model, the peer may need to travel around the community to work with many institutions, some of whom may take some responsibility for training or supervision. But generally, the greater burden for those things rests with the original organization, the host organization, as with World. As you might imagine, maintaining good communication between these various entities is a bit more of a challenge in the external model. Now, this slide, again, looks very busy, but I just want to focus you on a couple things. This is a tool that we used in helping organizations plan their programs. And I'd like to just focus on the top row and the left column, and not worry so much about what's in the middle of the table. The content here relates to a hospital infectious disease clinic that wanted to start a peer program. They had great potential. They had received a grant, so they had seed money. They had a champion in the clinic's medical director. The medical director really liked the idea of having a peer program. And they had a committed group of staff and patients. The technical assistance we provided them focused on moving from a program with a single unpaid volunteer to having a staff of peers and a greater variety of tasks for the peers. I should add that they created a great program that's still ongoing. So on the left column are the major tasks that you need to think about. And again, this corresponds somewhat to the table of contents in the toolkit that I showed you before. And then looking across the top row in blue there, the tool asks you to define certain things. What exactly the activity is, who's going to be responsible, in what time frame, what the desired outcome is, and what technical assistance or resources need to be brought in so that can happen. As I said, part of your action program should focus on winning over or neutralizing people who are resistant to the program. It's not unusual for providers such as physicians to feel threatened by peer programs. And in fact, one of the other resources the Peer Center offers is a wonderful short video about overcoming provider resistance, where both a physician in California and a nurse director of HIV services at the Kansas City Free Health Clinic talk about their experiences about being initially very resistant to having peers involved in what they called their patients, and then coming to realize all the things that peers could offer that as physicians or managers they could not. There were a couple organizations we worked with where perceived breaches of confidentiality, I'm not sure those are always real breaches, but perceived breaches by peers made it very difficult to overcome resistance among providers. Now, this table looks similar, except instead of having all the different areas of activity, this focuses on one. So this is a detailed use of the same tool to focus on one activity, which is the referral process. And I just want to add, I mentioned confidentiality a minute ago. Despite it being a major concern of providers, I've never found it to be a problem in the peer programs that I've worked in. In my experience, peers are also patients themselves, and they're very sensitive about what information gets thrown around in a clinic. I feel it's sort of like the golden rule. You don't do unto others that you wouldn't want to have done to you. So I found, if anything, peers were overly sensitive about what information they could share, and sometimes we had to remind them that as part of a treatment team, it was okay to tell us some of the things they've learned about the patients. So let's take a moment to talk about recruitment, hiring, and training. A lot of times people come to us for technical assistance and say, well, we want to run a train program. And we'd say, well, what is your peer program going to do? And the response is, well, we haven't figured that out yet, but let's train them first. I would say that's getting the process backwards. I think what you need to do is first figure out what your program is about using the ideas that we've seen over the last couple slides, the organizational readiness and the program design, and then you know what to train the peers on. As this slide suggests, you can't rely on traditional human resources methods for recruiting and hiring peers. A lot of peers don't have a resume, or if they actually worked up a resume, it may not look in the way that we're accustomed to seeing resumes. They may not have extensive work histories. Most of the peers we worked with at Harlem Hospital did not have high school degrees. So I'm not opposed to looking at resumes, but I think you have to figure out other ways to get to know what an applicant for a peer position is about. And one of those might be just sort of doing more interviews, maybe a screening interview over the phone, a face-to-face interview where you talk to the person about their experiences and their motivations for wanting to be a peer. In fact, that's another thing offered in the toolkit is some ideas about the questions one might ask. A key issue is their views about disclosing information. I've had peer candidates tell me, well, in the AA tradition of anonymity, I don't want to disclose anything. And my response has been, then why would I hire you? Because part of what being a peer about is using that personal experience. That, the experiences of having been diagnosed, of taking medication, experiencing side effects, that is valuable. Now I have to say that what I have learned over time is that you need to give the peer the freedom to disclose when and what they want, that a person just can't be expected to be introduced, say, to a client like, here's your peer, he's HIV positive too. No, that's not the way you do it. In fact, one peer had said to me that she always views her disclosure as like an extra tool she had in her back pocket. And sometimes when working with a client and the client's complaining about, oh, this medication, it's horrible, then you can say, well, I'm taking it too. And this is how I deal with the side effects, or it can be very powerful. But again, I don't think I'd ever hire a peer who absolutely refused to disclose this sort of information. This slide shows the main topics that we used in our trainings, both at Harlem Hospital and then when we were funded by HRSA to do trainings to a variety of organizations. Having a comprehensive training program of this type is realistic when you're starting a new peer program where you need to train a good number of peers, or if you're training a number of peers who might go off to work in different organizations. There's basic information about HIV 101, about the therapy, about opportunistic infection, secondary prevention, adherence strategies. There are skills such as counseling techniques, advocacy, and then just talking about the role of the peer worker, because most people don't know what a peer is. And if you're a client and someone says to you, here's the peer who's going to be working with you, most people probably go, what? And that's also the reaction among many providers, too. So talking to the peers about how to present themselves and how to explain what they do is important. As I said, sometimes you may not be in a situation where you can afford to do a comprehensive training like this. You may have a small program. You may be only replacing one or two peers in a larger program. And in such cases, the training may consist more of self-study materials and shadowing existing peers. That can be a very valuable experience. This picture shows two trainees in the closing exercise of one of our trainings, and I added it just to remind myself and to tell you that training is not just about giving people information or developing skills. It's also about building group solidarity among the peers. Even if these peers won't exactly be working together, if they be going off and working for different organizations, to feel that there's other people who they have things in common with, who can also serve as support to them, is very important. Now, I referred to earlier the fact that we created two toolkits. While this has a similar design of the cover, this is the second toolkit that focuses on training. And it does two things. It offers a lot of information about how to organize a training, and then it also provides a large number of curricula on the many topics that you may want to train peers on. Now, again, this is for HIV-positive peers, but even still, there are many curricula within this toolkit that I think would be useful across a variety of settings. So say if there was a particular topic you needed to train your peers on, say adherence to antiretroviral therapy, what you'll find in this toolkit is probably 4 or 5 different curricula around that topic. They will be the curricula that we used in our different sites, so they'll naturally have a different nature or different focus, but they will also probably have different lengths based on how important that issue was for different sites. Now, because we used peers for treatment adherence at Harlem, we had an extensive curriculum on adherence. Some of the other sites emphasize that less, and theirs will be briefer. So that gives you more options to find a curricula that works for you. And it's sort of like, going shopping. There's not just one type of beans. You can choose from a variety of beans on the shelf or breads or whatever. And that's what this toolkit offers, is sort of a supermarket of training curricula. It's located online at the address shown at the bottom of the slide there. I still have a number of slides coming up about supervision and a couple other topics, but I wonder if this isn't a good time just stop and take some questions if people have questions. Amanda, would that be all right?
Absolutely. Diane, can we queue up the questions?
At this time, I would like to remind everyone, in order to ask a question, press star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster.
And again, Paul, these toolkits are available currently just at this web address.
Yes.
Great.
Again, if you would like to ask a question, press star, then the number 1 on your telephone keypad.
And as a reminder, at any point, if you feel more comfortable chatting your questions, you can do that in the bottom right-hand corner of your screen and just send it to Amanda Hopping-Wynn, and I will address those questions to Paul when he stops next. Do we have any questions queued up?
There are no questions at this time. I turn the call back over to the presenters.
Thank you.
Okay. So there was a question at the previous time we stopped about supervision, and that is an important issue, so I would like to take a little time to talk about that. As I think I indicated earlier, peer workers serve on what I call the front lines of our work. Now, this is true in HIV, but I think in other areas too. There are other areas in which peer workers or community health workers have been used. It's a challenging role. They have more time to speak with clients, and thus they can learn a lot of things that the client will never have time to talk about with a physician or a nurse, about problems in their lives, about what makes it hard to take their medication. Again, these are coming back to HIV examples, but I think it would be true in other areas too. So they could be getting a lot of content or a lot of problems thrown at them, and it may be difficult to sort out not only what to do about those to help the client, but also how far they should go personally in addressing these things. So it's only through careful supervision that we can help them deal with this variety of information that comes out. Now, regardless of what role they're playing, peer supervision needs to include regular meeting times, on-site administrative supervision where the peer is located is ideal. Now, this slide throws a couple terms in here about administrative supervision, supportive, and clinical supervision. The next couple slides will define the differences between those types of supervision. But in general, I'd say you shouldn't have the same person doing administrative supervision and either supportive or clinical supervision. Supportive supervision can be provided by a non-licensed practitioner. Clinical supervision is always provided by a licensed practitioner, social worker, psychologist, etc. Administrative supervision should be offered to all employees as part of good program management. So administrative supervision includes such things as goal setting, including the number of clients the peer workers can work with, what types of supportive work peer workers should be doing, what are the program goals, and how is the peer worker supporting those goals together with the team. Any professional development issues, including training they might need to help them in their activities. Troubleshooting any administrative barriers, such as client contact information, confidentiality issues, working with other members of the care team. Managing logistics, such as vacations, sick time, varied work schedules, and working with the peer to review the goals of their work and the progress on these goals. And checking in with them about job satisfaction. These are all things that are part of administrative supervision. And again, we have tools available in the Building Peer Program Success Toolkit, the first one I showed you, that helps support administrative supervision. Supportive supervision is a little different. For people who don't have, well, I should say for people who do have clinical background in social work or psychology, have been trained on such things as addressing their client stresses. Peer workers generally do not receive that sort of training, and they may not know how to engage their clients in a trusting relationship in order to support them. So supportive supervision is the opportunity for the peer and supervisor to talk about issues that emerge as a result of the peer's own life experience in working with clients who are in similar situations. These issues are directed toward helping the peer both maintain their boundaries and manage within the scope of their work. Sometimes feelings emerge as a result of working closely with clients. These feelings can be addressed as part of how they're working with their clients. And unlike clinical supervision, supportive supervision does not dig deeply into the deeper reasoning behind these feelings, but rather looks for ways in which the peer can contribute to support the client's goals and still feel themselves supported in maintaining their own boundaries. Supportive supervision should be offered regularly with time that is set aside for the peer worker to provide a safe and uninterrupted time. Clinical supervision is something that's offered both to pre-licensed practitioners, licensed practitioners, as well as peers. So obviously, social workers and organizations often have clinical supervision themselves from their supervisor. In some places, programs that provide different forms of counseling are required to have clinical supervision. Certain states require that. Now, working with the clinical supervisor, the peer has the opportunity to explore more deeply the feelings that might be stirred up by the client relationship, something that's known as transference and countertransference. And unlike supportive supervision, clinical supervision allows the peer worker to develop a deeper understanding into how their reactions can be triggered by the client. It's through this understanding and exploration that they can maintain a relationship with the client that's productive. To be honest, many programs are unable to afford clinical supervision for peers, although I do believe it would be very beneficial. So this slide shows various forms of support and supervision we offer to our peers at Harlem Hospital. And let me draw your attention to the third bullet. We encourage our peers to meet together to discuss the stresses of the job, off-site and without any professionals involved in these meetings. Now, I believe this mutual aid support group was really beneficial, although I have to say it seemed to fall apart each time one of their colleagues died, because we did have a number of peers who passed during the time they were working for us. I worked with something upwards of 30 peers at Harlem Hospital. The quarterly peer forum, the fourth bullet, was a way to come together every couple months just to evaluate informally how things are going. And that often led to the final bullet where the need for certain in-service trainings was identified. Now, retention, I think, always has to be discussed in light of supervision, because I think there's a direct relationship to how well people are supported and supervised and whether they stay as peers. In my experience, we had very good retention of peer workers, and I would say retention is enhanced when the peer feels valued as a member of a team, that he or she is offered opportunities for growth, whether that be further training, presenting at conferences or other public meetings, or even considering moving up to full-time positions. While we've had peers on one hand who say, I'm happy in this role, I think I'm contributing in this role, other peers have said, you know, I really like working with people, I'd like to get further training and become, say, a case manager or a case, well, it's called different things in different states, but someone who specializes in substance abuse and that certification. And we've had that experience with people moving into full-time positions. As I said before, good supervision is essential. Their peers are more likely to stay when they receive support and guidance and when they have clear expectations of what they're supposed to do.
And Paul, I'd like to stop you just for a second.
Sure.
We have a question from Alexis Balke about supervision, and she wonders what the recommendations are for the frequency of both types of supervision.
Well, let me just go back. I think I said in the previous slide, the weekly individual case review refers more to the administrative supervision. It could be biweekly. We tended to have biweekly case management meetings, which is a form of supervision, but it's also a form of problem solving and idea sharing. One of the peers could bring a problem that they have to the biweekly case management meeting, like, you know, I just can't connect with this guy. I don't understand why he's not returning my phone calls. And they could sort of brainstorm about what do we do about that. And that's different than a peer coming to their administrative supervisor say, I can't connect with this guy. I mean, obviously, more people around the table leads to a greater variety of suggestions, but it's also more of a cooperative, collaborative process instead of when a peer says to their individual supervisor, well, I can't connect, it almost seems like, well, this is your problem, how come you're not connecting? And I think in the sort of group case management meetings takes on more the spirit of, here's a common problem, let's share the different things we've done over time to overcome that. Clinical supervision is probably not nearly as frequent as weekly or biweekly, probably more like on a monthly basis.
Great, thank you.
Mm-hmm. Okay. The final point I want to make about retention is, again, this is focused on the HIV world, but again, probably still pertains to other settings. Retention is impacted by the fact that the workforce has a serious and chronic disease, HIV, and a peer supervisor has to take this into account when planning the workload. I referred briefly ago to the number of peers who passed while working for us, but many of them suffered health problems where they had to stop working for different lengths of time. And it's important for a supervisor to be prepared for those. I don't want to say anticipate, but be prepared for those circumstances. Because you don't really want the situation where a peer who's very much liked and popular has to take a medical leave and no one knows his or her clients and his or her clients don't feel connected to any other peer. That's a way to sort of lose people. They may fall out of treatment when they don't feel the support from the person they know and respect. So the supervisor needs to think about ways in which not just a single peer, but a variety of people have knowledge about the clients that they're serving. Okay. I want to talk briefly about evaluation. It's a topic that could merit a webinar on its own, but I just want to make a couple important points about evaluation. So why do we want to evaluate our peer program? Well, to understand the processes, which is to monitor progress towards goals, identify what's working, what's not, improve our practice, and enhance successful activities. We also want to identify outcomes, because it's through outcomes we can show the benefits to target communities and populations, or I could say particularly funders. And outcomes provides evidence of effectiveness. It will strengthen your arguments for having peer services. So the benefits of evaluation are to provide information to guide and advocate for program improvement. Which specific services are acceptable to clients or patients? What is feasible for staff to implement? And are our current activities leading to desired outcomes and program goals? It's a way to systematize good management practice. Which program activities are making a difference for the outcomes? And to validate the successes. Now, here's some of the things I think that some of the ways in which clients benefit from working with peers. Improved medication adherence, greater retention and care, greater clinical enrollment among people who test positive for HIV, increased use of support services, substance abuse treatment, social services, etc. I wouldn't say that we have definitive evidence of the effectiveness of peer programs across all of these areas. There are a handful of studies that present limited aspects of effectiveness, and it is such an unfortunate fact that there hasn't been the one very good study that sort of knocks the ball out of the ballpark, in terms of really showing that peers are uniformly successful. I think anybody who's worked with peers is convinced of the value of having them, that having a peer program benefits both the clients and the peers themselves. And this slide shows you some of the quotes that we collected from clients about what impact the peers had on their life. The first one, she gives me tips on how to take my meds. I take it with food, that it is better to take it with something to drink. I take my medicine better than the way I was taking it. The second person said, I found out all the details of HIV. I knew HIV was something people had, but I didn't know how they cared for themselves or how they could get it, how it's transferred. I didn't know any of that until I sat down with my peer. Another person said, I know if I work long enough with my peer, she can show me the tricks to reach out to other women like me, how to go out and get people to come and not be ashamed of their status. I would like to help somebody. Now, again, these are actual quotes from clients. It's important to collect this sort of information. A lot of times when people hear the word evaluation, they think numbers. We have to start counting things and adding up numbers. But it's also important to collect these sort of quotes because these are heartfelt statements about how people benefited from having a peer. And that can be as equally as important as the statistical evidence. Okay, and finally, I was asked to address sources of funding, and I wish there was a magical answer to this. Peer programs have not received the level of acceptance that the major funders have all jumped in to support these programs. In my experience with the HRSA Ryan White programs, which are the HIV/AIDS programs funded by the federal government, my experience was that whether you could charge peer programs to your Ryan White funding depended a lot on the HRSA representative in your region, that some of those representatives would view those as adherent support activities and thus they're allowable expenses, and others would not. The CDC has shown some support for this idea. They've used the term more community health workers and operated in areas other than HIV, in hypertension and breast cancer screening, several other areas of public health. Our funding came a lot through the National Institutes of Health or through research funding, where we propose research projects. There's also private foundations and corporate funders. The MAC AIDS Fund was an organization that funded a couple of the organizations I've referred to, the hospital-based infectious disease clinic one, et cetera, with small grants. And you need to approach your local or regional HIV/AIDS planning councils. Now, I used to think that obtaining funding was a major issue because then you could pay your peers. And my belief in that came from the idea when you think about our society, we often don't value volunteers. The fact that somebody gets paid to do something indicates that that's valuable. So like if you're getting paid, then you're worth it. And if you're not getting paid, well, you're a volunteer. I have to say I've changed my mind considerably about this. It's partly because I've come to realize that peer programs don't need a lot of money to operate. Again, in the HIV field, if you're hiring HIV-positive peers, they're generally receiving federal benefits that put a limit on how much they can earn. And it's also because I've come to feel that if you just not have the resources at this time to pay your peers, but you have peers willing to volunteer, it's better to start that way. And then as the program slowly builds, you can start to look for ways to seek funding. And as I said in the beginning, we've always found peers who are willing to volunteer their services because their commitment to doing something about HIV/AIDS. So, coming to the end of my presentation, I just want to make a couple points. You've probably heard me say repeatedly. Peers can be full members of the care team. They can play many roles, from patient navigation to enhancing adherence and running support groups. You have to give considerable attention to supervision, and it's important to document their activities and outcomes. An important facet is to have a champion, someone who believes in the power of peer work and who will fight for the program. And it's probably more important to have that than obtaining funding, because you can do a lot with volunteers. Also, as I said earlier, it's important to carefully assess organizational readiness. If others in the organization don't buy into having a peer program, important staff can be reassigned and the program falls apart. I would like to close with this quote from a physician who works with the World program in California. I think the most important thing my patients get from working with peer advocates is hope for the future. No matter how much I talk to them about the potential for them to live long and healthy lives, seeing someone living that promise is more powerful. And finally, here's just some pictures from World of some of their clients and peers together. And I think this is a good time to stop and take questions.
Yes, I would like to spend about 5 minutes on questions for you, Paul, before we turn it over to Tina. Diane, do you mind queuing up the lines for questions?
Not at all. At this time, I would like to remind everyone, in order to ask a question, press star, then the number 1 on your telephone keypad. We'll pause for a moment to compile the Q&A roster.
And we do have some chat questions that have come in from Susan. First one is, how can you tell the outcome is related to peer mentors rather than case managers or clinical staff when you're evaluating? Is there a specific instrument that you use related to the peer work?
Well, I guess if you're thinking program-wide, it may be that you don't have a peer assigned to every client. So you could look at outcomes across who had a peer versus who didn't. I mean, that sounds sort of researchy, but it doesn't need to be in some sort of randomized trial way. It could just be simply observational. If you don't have resources for each client to have a peer. There are some models in the toolkit of forms used for documenting peer activities, and something that we found important at Harlem was to have something that's not burdensome in terms of paperwork. I mean, no one loves paperwork, but for people with a peer background who often don't have work histories or even have poor literacy skills, to ask them to write like progress notes longhand is really a bad idea. So we developed a checklist type format where they could report on their interaction with a client by checking boxes like where it happened, was it in person or over the phone, how long, what issues did you talk about, how well did it go, what other services did you provide like referrals, and you can use that information to compile. And getting back to then the difference between what the peer offers and a case manager, it might be through the very activities that are reflected in that data collection that you could see, well, this is something, taking a half hour to talk to the client about their adherence is something the peer would probably be doing, but a case manager wouldn't have that amount of time. So that's just some thoughts off the top of my head about that.
And then she also asks, are there states that you know of that peers can be paid under Medicaid?
I have to say I'm not qualified to answer that question. I didn't have so much to do with that.
Okay. Dan, do we have any calls on the phone?
There are no questions at this time. I will turn the call back over to you, the presenters.
Thank you. Well, at this time, I'd like to turn it over to Tina Rodriguez, who is a peer in the field, to hear firsthand her experience of being a peer. Tina, are you there?
Yes, I am.
Great. I'd like to turn it over to you now.
Hello, good afternoon, good morning to some of you. So what I want to talk about first is why I became a peer model specialist, which I think is the most important and the most powerful piece behind the work that we do as peer model specialists. I'm a child from a mother with an addiction, and I grew up with a quite hard childhood, and me being a peer model specialist gives me the opportunity to not only help mothers be the mothers they really want to be, but also for the children to be able to, grow up with their mothers healthy in a stable life, opposed to growing up with a mother, with addiction and not having the right supports and help that she needs. So that's one of the biggest reasons of why I do what I do, because I've lived with so many familiar and similar situations that I like to bring that to my work. Clients prefer peer support, I think, over, in some cases, other professionals, just because we can relate to each other, share stories. I know that in my cases, I give a lot of my clients hope that change is possible and that recovery is possible. They have a good sense of not being judged very trusting with us. They tend to be more honest with us in regards to, a relapse or a situation that they might feel unsettled about telling their workers about. And I think the most important thing is we're strength-based. We always pull from their strengths when we're working with our clients in regards to anything, whether it be a relapse or their parenting or regards to that. We want to really pull from their strengths and let them know that it's okay to make mistakes upon the way, and that's a part of change. The next piece, I think, which is really important, is the training and support, which Dr. Colson talked about, supervision. I know in my agency and for my support, supervision is very key. It not only helps us better serve our families, we're always able to learn something new. Our supervision gives us a chance to, like Dr. Colson was saying, just really get take from your supervisor on what you're doing, if you're stuck with something, if you're having problem connecting with someone based on your personal feelings or whether it be a different trigger for you, and make sure you have the right support with your supervisor. And I recommend supervision, especially administration supervision, to be weekly, just so you can always sit down, go over things, make sure you're not overwhelming yourself, as we are peers ourselves, and making sure self-care is always number one. I think trainings are important when becoming a peer worker, as, again, we're coming into this field just based on our lived experiences, so I think trainings are important, especially with dealing with different subjects. It could be loss, it could be domestic violence, sexual abuse. Those are all things that everyone could use training around, and I think that in our agency we do a lot of trainings, not only with just staff but with clients as well, whether they be graduated Fresh Start clients or current Fresh Start clients. We work really hard to make sure that we are learning as much as we can and in portraying that to our clients as well. Through this work, there can be triggers. There can be things that come up for you that might have happened to you in the past, and on a good note, you can relate with the client with that, but on some notes, it might trigger a feeling for you or something that makes you uncomfortable. I think some of the things to be aware of when working in peer model recovery is, number one, is self-care, knowing your limits, being aware of your triggers, and knowing when that comes to, having the right skills to be able to deal with that, whether it be go to your supervisor and have a talk, or your clinical supervision outside of work. And I think the biggest thing is to know when you need a break, either mentally or physically, knowing that because you're no really good help to anyone if you're not taking care of yourself, number one. So just making sure that you're aware of your limits and what you can do. And I think for any peer model recovery group, whether it be HIV, substance use, or anything, having a great support team, professional and personal, is key in regards to your self-care and the care of your clients. Some of the other things I wanted to just elaborate on a little bit was peer model recovery and peer models can have a huge impact on other providers, whether it be DCF, hospital, physicians, any kind of providers, your mental health. The impact that it has is that by us working as peer model recovery specialists, we're actually like the example, the sample, the change is possible. I was where this client was at one point, and now I'm here, and I'm her her family recovery specialist. And the impact that it has on all providers would be that change is possible, recovery is real, addiction is real, relapse is a part of recovery. And some people are just uneducated and weren't shown the proper skills and tools to live life and deal with life on life's terms. So in some cases, we're just there to support them, educate them, show them different ways of coping with things opposed to using substances. And I think the biggest impact it has is we're all working together instead of working against each other. I think when you have a client and you have a team who's working together, whether it be DCF, the doctor, the mental health, When you're all on the same page working together in for the client and for the client, I think the outcome's always better. The communication is stronger, and you're able to address things with a better fashion than nobody communicating and no one knows what's going on. And I think one of the things I've seen in our program is that I have DCF workers now calling me and asking my opinion on a relapse or what to do or what steps do they take to get back into recovery, which is viewing us peers as a professional, which is huge. And to me, that's phenomenal. And our agency as a whole, we are a Fresh Start program, but we work under the agency Square One. And I know our agency in particular is really, really sufficient on making sure our self-care is done. We're allowed time during the day if we need to do, if we wanted to do a therapy session. We have a lot of diversity in our program where our agency has opened up our agency to NA meetings with child care. We have a Medicaid-assisted treatment NA group. And our agency has just come around and really looked into this peer model and really accepted it and has found ways to work it into not only their agency but around the community. And I think one of the things I want to leave you with is that change is possible, and that our goal for our peer model recovery project is that eventually our participants will graduate and become family support specialists and keep the ball rolling as people keep revolving into this life of recovery and being able to get out there and work and have a professional title. And what I want to say is that one of our coworkers, who was our first Fresh Start client, who is on medication-assisted treatment, is one of our family support specialists. And I have to say she has a huge impact on our clients and the work that we do, because she is living proof that, change is possible and that our program actually works. And that's all.
Thank you, Tina. I would like to, again, open the lines for questions. Diane, are you available?
At this time, I would like to remind everyone, in order to ask a question, press star, then the number 1 on your telephone keypad. We'll pause for a moment to compile a Q&A roster.
Now, Tina, you talked a little bit about your interaction with DCFS, Division of Children and Family Services, there in Massachusetts. I'm wondering what the training is on child abuse reporting laws for peers. So if you are working with a client and you suspect there might be child abuse in the home, is there a standard protocol that peers are to follow when that happens?
Yes, upon receiving and getting this job title, we have many trainings around mandated reporting. We are mandated reporters just like anyone else. That is something I'm very honest with my clients from the first meeting, so that they're not, thinking I held that information from them or anything like that. But yes, we're mandated reporters. I myself have had to, file on some instances where, it had to be done. But yeah, we follow normal protocol, mandated reporting. The first thing we would do is always come to our supervisor and, go through the protocol steps with her in regards to reporting on it.
What has your experience been with the relationship with the client after you have to report?
Well, in my experiences, I try to, depending on the situation and the severity of the situation of what it is, what I like to do is call with the client, call the DCF worker together, let her know what's going on. And in the case with that, the client is more apt to work with you still. They're not like you did it with them. You didn't go behind their back and call DCF, and you were there with them, supporting them why they had to tell them this information, whether it may be, some harmful information or something that's going wrong. And I see it that the more honest you are with them, the better. There has been instances when I can't tell the client. Even in that case, things have gone over smoothly, and, they have seen that it was something that needed to be done, and it was for the safety of the children. And most clients can look upon that and appreciate that.
Well, I have a few more questions, but I should probably see if there are any questions on the phone first.
Okay.
Your first question comes from the line of Susan DeFlippino. Your line is open.
Hi, this is Kathy Crowley again. I just wanted to say to Tina, thank you so much for sharing your experiences. I work mainly with substance abuse treatment programs where they utilize the peer recovery model. And you did talk about substance abuse several times throughout your discussion, and I just want to let you know that if you know peers that are in recovery from substance abuse, there is a movement, and hopefully within the next year they are looking at national accreditation for peer recovery specialists. So just to keep that out.
Thank you.
But thank you very much.
Thank you.
There are no further questions at this time. I will turn the call back over to the presenters.
So, Tina, I'm wondering what your typical caseload is. How many clients are you normally working with?
I usually work from either 10 to 12. It would only be 12 if I had a client that was close to graduating and she was on a monthly basis or like a maintenance type of client. But usually it's 10 or 12 clients at a time.
And is that weekly visits or as needed? What does that look like?
I guess depending on the client, depending on where they are in their recovery, their needs for parenting, because we base ours around parenting and recovery. So I like to let the client make that decision, and in some cases I'll let them make the decision. They'll say, "Oh, I want you in 2 weeks," and then after the first visit they'll call me. They want me weekly. Mm-hmm. So in my cases, like I said, I usually leave it up to the client unless, I've had clients that are, very new in recovery or still using, and I suggest, maybe we should meet weekly. I even had some clients that I did on twice a week. Those are more severe cases. But it all depends on the client and where they're at in their recovery and what needs and services and support they need.
Makes sense. I guess this next question I have is for both Paul and Tina. As far as training goes, Tina, did you have training on personal safety? And Paul, is there a module in the link that you listed earlier in your slides that addresses personal safety for peer workers?
I know for me, we have extensive training on personal safety, and we're always going to new trainings about personal safety and keeping up to date on all the new things. We just had our agency just approved for us to white out our last names on our badges as opposed to a safety precaution. But yes, we were trained. When I go into a home and I visit, I look at the exits. I count how many people are in there. I always keep myself toward the door to make sure I can get in and exit. If I ever feel uncomfortable in a situation, I have a phone call or I have make up something and excuse yourself without causing, or making a scene where they know that you think something's wrong. But yes, extensive training on safety. In some situations, if I feel unsafe, two of us will go out at once, and we have outlooks so that our supervisors know where we are at all times.
Great.
Yeah, I was just looking through the toolkit. I'm not familiar with the training toolkit, and there may be training curricula there. In the program design toolkit, it's not mentioned as an issue. Not to say it's unimportant, but to the extent that we might have been conscious of that as an issue, I think we felt that it might vary too much by the different situations that agencies work in. I've also, as you said in the beginning about my qualifications, I've also worked in tuberculosis control. And the New York State Department of Health had a lovely video about safety in the field that all had to do with, where you park your car and things like that. And in New York City, it didn't really apply very well. I think both the sort of neighborhoods we work in and live in and what the risks are can vary considerably, although there are common tips also, as Tina's mentioned. So I guess I have to not give a very good answer on that, but it's an important issue. I'm just not sure how much material we had in our toolkits about that.
How long was the average period of training before a peer could start working with clients in both of your experiences?
Well, for us, that comprehensive course that we offered prior to starting a whole peer program was usually a couple weeks, but not every day, all day, being cognizant of the difficulties that sort of rigorous training might pose for our HIV-positive peers. Although, when we trained for our own programs at Harlem Hospital, we were very cautious about that. It only did half-day trainings, things like that. Once we opened up our trainings to people in New York City or even the whole Northeast region, sort of for efficiency reasons, we went to full-day trainings. Particularly if somebody has to travel to the training and you only offer a half-day and they have to come back 3 more times, it's not as viable as maybe just 2 solid days of training. And also, I would say another factor is with improved medications, I think many HIV patients are having a higher quality of life and thus more energy and perhaps fewer side effects. Because we started our first programs in the mid-'90s when the highly active antiretroviral treatment was just coming in. And by the mid-2000s, when we were training with the HRSA money, it was a very different situation in terms of medications.
Sure.
So I think in our case, it's a little bit different. So I think for us, I know in my case, it was a couple weeks of really going over, the safety, the mandatory reporting, parenting, assessments, all those things have to be put into your training. So I would say a couple weeks, but also what really helped me was the shadowing. Is we do our training like, a normal training in the office one-on-one where you get all those trainings, but I think the real work is when you go out and shadow, and I did that for a couple weeks before I even went on my first visit, where I was given the chance to shadow, watch a visit, see a first-time visit, listen in on phone calls, and I think the hands-on stuff was what really helps us be better at what we do.
Yeah, that is a great component. Well, I'd like to provide one more opportunity for any last questions before we close up here. Dan, do we have any questions on the line at this time?
There are currently no questions online, and if anyone would like to ask a question, press star, then the number 1 on your telephone keypad.
Well, I'd like to thank both Paul and Tina so much for being with us today. I think it was a really nice mix to get both of your perspectives. I think it added quite a bit to the conversation. As always, we greatly value and consider the feedback of our participants, and we'd love for you to link to our brief online evaluation form after this call and take a few moments to complete it. It'll automatically be sent back to us. And if you're sitting in a room with several people, if each of you could take some time to complete the evaluation, it would be incredibly helpful. And with that, thank you, presenters. Thank you, participants. This is the last webinar in our 2012 series, so keep your eye out for information regarding the 2013 series. And if you happen to be on our website, which is aia.berkeley.edu, you'll see some information for our national conference, which is taking place September 10th through 12th in Austin, Texas. It'll be nice and hot. It's called Strengthening Connections Between Parents and Children Affected by Substance Abuse, HIV, and Trauma. And you can find all the details on that at aia.berkeley.edu. So thank you again to everyone who is listening in on the call, and thank you to our presenters, and I hope you all have a great day.
Thank you. Have a good day.
This concludes today's conference call. You may now disconnect.